Good afternoon. Nobody ever does that. Thanks. We could wrap up now. My name is Steve Terrett. I'm the school's Associate Dean for Faculty and Education. And today is an exciting day for the school. Today's not just an exciting day for the school. Today's an exciting day for public health. Today's an exciting day for the school's Center for Injury Research and Policy. This is the launch of National Public Health Week, and it's an honor for the Johns Hopkins Bloomberg School of Public Health to be a meaningful part of the launch of this week. As being a co-host along with the American Public Health Association for this kickoff event. This year, National Public Health Week is looking at the theme of safety is no accident. We're looking at what we, for decades in the school, have called the field of injury prevention or injury control. I was saying in a meeting just a few moments ago that it was in the early 1980s, around 1983, that Sue Baker and colleagues decided that we would hold the first national conference on injury prevention. We had no shyness about us here in the School of Public Health. Our only problem was not what you might think, which was getting funding for that. We did get funding. It was from the Centers for Disease Control, but our problem was trying to find 20 people within the United States who had at least a passing interest in injury prevention. The world has changed significantly since then. There's a meeting that's about to happen later this week in Iowa of an organization for which Dr. Andrea Geelan is currently the president of, dealing with the prevention of injuries and violence, and the enrollment for that conference is 375 people. So we've come a long way in the field of injury prevention. We've come a long way based on statistics, such as the incredible drop in motor vehicle fatalities that's occurred. Back when I started in the field of public health and in injury prevention, there were about 52,000 deaths per year on the highways. In the most recent year, for which data are available, that's more like 33,000 deaths. Again, we've come a long way. We've come a long way in developing the human capital, but we still have a very long way to go in the field of injury prevention. Injuries still represent the #1 cause of death for people in the United States from ages 1 to 44. And it's events like this, concerted efforts like this, that will address injury prevention. In order to do that, we're extraordinarily fortunate in having 3 of the leaders of the nation to come talk with us about the field of injury prevention. I'm going to introduce them just very briefly because you have a brochure that gives you a little bio sketch for each one of them. But our first speaker today will be Dr. Georges Benjamin. The school and Dr. Benjamin are old friends. Dr. Benjamin served as the secretary for the state of Maryland's Department of Health and Mental Hygiene for years, and now serves as the executive director of the American Public Health Association, putting him in a position to be one of the strongest influences on protecting the health and the well-being of populations, not only in the United States, but elsewhere around the world. Our second speaker is also a dear friend of the School of Public Health, and that's Dr. Josh Sharfstein. We first got to know Dr. Sharfstein after he had become a pediatrician in a city far to the north of here, but he returned to his hometown of Baltimore to become the health commissioner for the city of Baltimore. He did courageous, wonderful things, working not only in areas of injury prevention, but also in areas of food policy and other areas. And then he went on to be the principal deputy of the Food and Drug Administration at the beginning of President Obama's administration. It's only recently that Dr. Sharfstein came home to Maryland and now serves in the position that Dr. Benjamin previously served in as the Secretary of Health and Mental Hygiene for the state of Maryland. And our last speaker is our own professor, Dr. Andrea Gielen. Andrea has been at the school for some time. I remember before Andrea was at the school when she was getting her degrees here at the school and working in the area of child safety seats. Andrea has had a decades-long commitment to reducing the toll that injuries take on the public, particularly on children, and very appropriately, Andrea now, in addition to serving as a professor in the Department of Health Policy and Management, Andrea serves as the director of our school's Center for Injury Research and Policy. So we have a fast-paced program for today. I'll be sitting in the front row waving at people that their time is up, sadly, because we don't have a whole lot of time. But we'd like to begin with Dr. Georges Benjamin, followed by Dr. Sharfstein, followed by Dr. Gielen. Thank you very much.
Well, good afternoon, everyone. Let me just thank you very much for being here today as we kick off National Public Health Week. I remind you that National Public Health Week is the first full week of April every year, and actually has a presidential designation. We actually, several years ago, got the president to say that we are going to have a National Public Health Week. The American Public Health Association serves as the orchestrator for this prestigious week. And we argue that this is the week in which we are to not only celebrate our successes, but to let the public know a bit about what population health can do in terms of improving the health of the public. Let me start by certainly recognizing that there are many things that cause premature deaths and disability, and a whole lot of those things are preventable. But none of those things capture both the American attention or really go under the radar stream as much as injury. It is certainly the leading cause of death, as you've heard, for people age 1 through 44, and yet it often doesn't get acknowledged as such in terms of the resources and the attention that it holds. As I think a bit about this, not only as a leading cause of death, but also it's a leading cause of disability, both preventable disability in our country, and we need to pay a lot more attention to injury. Now, you know, it's also important for me to acknowledge some of the real giants in this field, and there's no greater giant in this field than Professor Sue Baker, and I just want to acknowledge Professor Baker's presence. I, like many of us in the injury world, really learned either directly or indirectly, as I say, at the knee of Dr. Baker. Her vision around injury is phenomenal, and I just want to publicly thank her for everything that she's done in this field. Having her here at the Bloomberg School, I think, is a real jewel to the faculty here. And if you don't know Professor Baker, you need to. She has forgotten more about injury than, frankly, than most of us know. During this week, we have tried to do many things around this theme, and I'm going to walk through each day of National Public Health Week. So day one is Monday. We want folks to focus at injury at home. Think about it. When you get up in the morning, there's just many things that you can do to make sure your home is safe. From the time you cut the water on, if you have particularly small children at home or someone who's more elderly or who's someone sensitive to heat, there are many very, very cheap tools you can use to make sure that if the water is too hot, they won't burn themselves. As you walk around your bathroom or in your stairs, if you have throw rugs around, there are ways to tack those rugs down so that people don't slip and fall. Even getting in and out of the tub can be a traumatic experience if you're not careful at home. As you get dressed and then go downstairs and go outside and get in your automobile, although we would encourage you to use mass transit if you could. But if you're getting in the automobile, remind you that those automobiles have been made much safer over time. We've made both people safer by focusing on impaired drivers and distracted drivers. We're working very hard, particularly on the distracting driving part right now. With seat belts and airbags and the way we designed these cars and the way we designed the roads, all of those things resulted in a multidisciplinary approach which has made getting to work much safer. But there's lots of things you can do in the home to try to make your home safer, including dealing with poisonings, making sure that the cabinets are fixed so that your children can't get into the cabinets. So just think about the kinds of things you can do at home to make your home safe. Safety at work is going to be our theme on Tuesday. Thinking about all the things that you can do in your work environment to make sure the work environment is safe. This is something that's important for both the employees as well as the employers. There's a whole range of things that happen in the workplace that we can make safer, and we want people to emphasize that and focus on that on Tuesday. On Wednesday, it's all about playing, both playing for kids and playing for adults. We want people to pay a lot of attention to safety at play, whether it is going into communities that have not so nice places for people to play. We want to get those places cleaned up and fixed so they're safe. We want playgrounds to be safe. We want the places where our children play on to be safe. And we want the places where we adults play to be safer. So we want to focus on that on Wednesday. On Thursday, it's on the move. So it takes us back to our cars. It takes us back to our bicycles. It's about all the things that we do to move from one place to another to make sure those things are safe and that we've done everything we can to mitigate the potential of injury. And then Friday, the last day of the week, is about our community. It's a much more population-based focus to try to make sure that our communities are safe. That's about our individual and our corporate responsibility as citizens of this nation to make sure those communities are safe and as injury-free as possible. Overall, our central challenge is making sure that we have convinced the nation that injury is a preventable cause of morbidity and mortality. That safety is no accident, but it does require planning, sound judgment, and ingenuity if we're going to be safe and effective as we go forward. I just want to encourage all of you to spend this week in a very, very effective way on each of these days, doing something that's important for the nation, doing something that's important both within your own homes and with your own families, with your neighbors, and really let's celebrate National Public Health Week. I thank you for your time this morning, and I'll turn it over to my good colleague, Dr. Sharfstein. Josh.
Thank you very much, Dr. Benjamin. People may not realize this. In addition to being a predecessor of mine in the job, he's also been a tremendous teacher and mentor to me over the years, even before I was the health commissioner in Baltimore. So thank you, Dr. Gielan, for having me, Professor Terrett. And it's also good, I think I saw Delegate Tarrant here. Just want to acknowledge him. Thank you for being here. I figure I will maybe get a little bit more specific than the broad overview that Dr. Benjamin gave and share some thoughts about injury prevention and the challenges and the the engagement, why it's such an important and interesting field. I recall being a pediatric resident and walking around the wards at Children's Hospital and seeing a child who had severe hypoxic injury to his brain. And I asked what had happened, and the child was going to have a terrible prognosis. And they said he had choked on a piece from the board game Aggravation. And I remember thinking about that there was a little piece in the game, he'd inhaled it, and he was going to be forever affected by it. And, I think, there are not too many things I remember from my pediatric residency, but I remember the you know, the irony and the anger and the frustration. I got to know the family about that. And, you know, you ask yourself, is it just bad luck? Some things happen, there's nothing you can do. Or is it preventable in some way? Are there things that can be done to prevent injuries like this? And I think that across a lot of different areas of injury, it's not that obvious. I mean, you're not going to ban a board game necessarily. Are you going to think about the warnings? Are the warnings going to help? You kind of walk yourself through the mentality. When you're a resident, you're just trying to take care of the patient. But I don't know, that one's kind of stuck with me. And I think that as I've worked on many other issues related to injuries, you realize why it's such an interesting and challenging field. Is one, the causality may be not entirely clear. Oftentimes injuries happen because there are 8 things in a row that have gone wrong. And it may be that one of them is a poor design and the other 6 of them are other things that could be modified, and you've got to figure out what the challenge is. It could be that, you know, one of the challenges is that there's pretty significant interests that are involved that wouldn't want to change the way they're doing things, and that can prevent progress on injuries. And I'm sure Delegate Tarrant could tell some stories about that. It could be that there are trade-offs, that if you look at it just purely as the injury side and you say, well, we're going to prevent the injury completely, that's our top priority, that suddenly where you wind up doesn't make sense. Like you could prevent all playground falls by banning playgrounds, but you don't want to do that. So what's the right place to draw the line? And finally, you've got to be sure before you do something that, you know, you don't have to be sure, but you have to have some idea whether interventions work. So you could have an idea that doing something would be helpful, but on the other hand, you really don't want to create more of a problem. When I was involved in the issue of over-the-counter cough and cold medicines, and we said, well, there are a lot of kids who've been injured by them, by overdoses, and there's no benefit from them, there was a big argument on the other side that if you take away ineffective over-the-counter cough and cold medicines, then, you know, parents will do much more harmful things, and potentially for children, and more kids will wind up injured. And there were some people on the advisory committee that was debating that who followed that. So I think for those reasons, that makes injury prevention sometimes kind of complex, but it makes it really challenging and interesting too, because on the other end, you really do have the potential to save lives. I was just going to list a few things that, you know, I know are out there as active issues right now, and show how these issues are kind of getting worked on. One of them I'll just start with is hot dogs. Causes a lot of choking. You know, there are clear recommendations. When I was at FDA, people said, you know, what are you guys doing about hot dogs? And, you know, part of the answer is USDA regulates hot dogs. You know, that's a good one. But you know, you know, you have a lot of an industry not so interested in putting warnings on hot dogs. Actually, a lot of kids, a fair number of kids, actually severely injured or even die from hot dog choking. Could there be something better done? Would it work? Is it just warnings? Are there other things? That's a very active issue that has been widely covered, believe it or not. Another one that's been kind of ripped from the headlines is crib bumper pads. There was a big expose in the Chicago Tribune recently about more than a couple dozen deaths where kids were smushed against the bumper pad and had asphyxia. They're not recommended. There's sort of a clear recommendation not to use in Canada, but not in the United States, where the Consumer Product Safety Commission hasn't taken action. And, you know, there's an industry that is not interested in doing it at this point, doesn't think that there's a problem, and it's very much an active issue. Gun violence, I'm sure you may hear from Dr. Gielan and Professor Tarrant about that. Obviously, there are a lot of interest, you know, a terrible toll of gun violence in the city of Baltimore and around the country, and there's some things that might be done. Are they the right things to be done? Who's going to oppose them? How do you accomplish something that's going to prevent gun violence? Another one that's close to, that I've worked on, it relates to pediatric overdose prevention. If you look at what's happened to child safety seats from the 1970s to now, it looks like, you know, an archaic, weird, springy thing, you know, to this like high-tech safety seat. But if you look at the technology for pediatric overdose prevention, it's basically the same kind of cap. That's it. Hasn't progressed. Well, why not? Why won't? Are there other models out there? In fact, there are. Single-serving uses, different things where you have to actually pull out a dose rather than just pour the whole thing out. Why aren't they being widely adopted? There are, you just walk around, and you can figure out that there are these potential impacts, which could really save lives, how do you actually sort through the various complexities? I would just say that in doing that, what I've learned is it's important, when prevention and preventing injuries is about preventing injuries to people who you don't know who's going to be the one who's injured. So it's, the dog that doesn't bark. It makes it much harder to talk about. And it's very important when you're doing that not to be shy about preventing a few deaths if that's what's going on. I remember one meeting at FDA where we were talking about oysters and a potential infectious hazard in oysters. And one of the congressional members said, I don't understand why you're so worked up about what you're describing are 15 deaths. And I said, well, the deaths, first of all, are like the most horrible deaths. I mean, the skin sloughs off. There's stories of people on their honeymoon, they had an oyster 3 days later. They're just in incredible pain. And I said, but, maybe understand this. Like, I mean, I'm a physician. Like, you don't get to, like, maybe as a pediatrician, you're not, like, saving lives every day. When you know that there are people who you can actually save, it doesn't necessarily matter how many of them there are. The right question is actually the balance of the costs against the benefits, and it doesn't make sense as a policy, not how many people. I mean, if I can save one child's life and do it in a reasonable way, I'm going to try to do it. And it shouldn't matter. And I think that, when you're talking about clinical care, and there's a child who needs something for treatment of cancer, a doctor will, be quite aggressive about how important it is to save that patient's life. And I think in preventing injuries, we should have that same level of aggressiveness. The second thing is we should be thoughtful about the balances I talked about before. So even if you are, you're thinking about a particular issue, you have to recognize that, well, we do want kids to go out and play outside. So where there are benefits, where there are economic costs, we have to be thoughtful about those balances. It doesn't mean just because there might be an economic interest out there, you shy away from it, but it also doesn't mean that you completely discount it. You've got to figure out how to be reasonable and try to figure out a path through. And when you can do that, it can be quite effective. And the last thing I'd say is that it's helpful to line up partners. Nobody wants to be seen as the scold who's saying you can't do this because, it's going to cause some horrible injury, and there are, a million ways to be ridiculed for doing that. But on the other hand, if you can bring together a broad group of people around an issue where you've been thoughtful and you can be very clear that you're saving lives or preventing injuries, it can be very effective. And I'll just end up with a couple of specific examples. Recently, when I was at FDA, we did a joint announcement with the Consumer Product Safety Commission about infant sleep positioners. And we said that they shouldn't be sold anywhere in the country. They've been sold for decades. We only talked about, I think, a handful, maybe 10 or 12 known deaths. That's it, the entire country. And yet we said that they shouldn't be sold, they shouldn't be used. People should just put them in the closet or get rid of them. And, there was some anxiety in doing that, how would people react to that? And one of the things that I suggested was that we have someone from the Academy of Pediatrics that supported this position on the phone call. And people were like, oh, I don't know whether we can do that. It's never been done at FDA before, and believe it or not. And we did that. We had a terrific pediatrician from Children's National Medical Center on the phone with us in the room. And she talked about all the things that could be done, why we didn't want any kids to slide down the infantile sleep positioner and have a problem with their neck or get their face pressed up against the side and stop breathing, and that there was absolutely no known benefit to these. And it went very well. I mean, within a day or two, they were off the shelves every place around the country. We had a good case. We had good partners. We explained it. Another one that I worked on related to caffeinated alcoholic beverages. I don't know whether, I doubt that they were sold in the your little coffee shop out here. But, one can would have 4 beers, the caffeine, the alcohol of 4 beers, the caffeine of like 5 Diet Pepsis, plus, the sugar of, who knows how many Krispy Kremes. And there were serious injuries that were happening. People were driving and getting into accidents. People were going alcohol poisoning. And there was definitely some anxiety about the right way to proceed, and we thought about it. There's not a lot of benefit from these products. There's pretty unique hazards. We explained why we thought it was different from other types of alcohol. And when we wound up moving forward, we had we did a phone call with a Republican and a Democratic state attorney general. We had the CDC there, and we had the Tobacco and Trade Bureau of the Department of Homeland Security there, and they said that they were concerned about it and they wouldn't allow people to ship alcohol in commerce if FDA was continued to be concerned about these products, and all those products went away. So, you know, you have the ability in injuries to really, by preventing injuries through policy, to really save lives. And it's exciting because it requires thinking through the politics, thinking through the science, figuring out who your allies are, making a smart decision about whether this is a target to pick or not. And in the end, it can be extremely rewarding. So I'm thrilled that National Public Health Week has picked injuries to focus on. I think that there's a tremendous potential all around us. And, you know, with the team you have here at Hopkins and with, you know, a lot of people interested in working on this, you know, I think that there's a lot we can accomplish. And I will end with this thought, which is that as the Secretary of Health, I have certain authority to take action when there's an unreasonable risk of injury. I'd be happy to hear from people at the school about where that might exist in the state of Maryland. The Health Commissioner of Baltimore has authority to take action against certain nuisances and hazards, and I'm sure she'd be interested in hearing. So that, you know, work that you all could do to identify and think through some of the challenges that I've been talking about could have an impact in our own community. Thank you very much.
Thank you very much, all of you, for coming here today to help celebrate National Public Health Week. Delegate Tarrant, we're delighted that you're here. Dr. Colmers, we're thrilled that you're here as well. And I thank our two distinguished speakers, Dr. Benjamin and Dr. Sharfstein, so much for your exciting and encouraging remarks. It was more than a little daunting to think about what I could contribute following such eminent speakers, but I will hopefully try to leave you with some ideas about how you can help to reduce the burden of injury in your community and in your country and in your region of the world, because to really address this problem means that we need all of you. And in keeping with the celebratory theme of National Public Health Week, I decided to address the question of what's so great about injury prevention. And I think there are many answers to that question, but I'll just share a few with you. And I am going to use slides, but please don't groan. Most of them don't have data on them. They're pictures. Okay, so what's so great about injury prevention? Well, first of all, you get to address a big problem. Not only do injuries affect the many people who you've heard, but they affect people daily and deeply. Injuries affect us all on a daily basis when something happens that restricts our activities, like a strain or a sprain or a broken bone. But injuries affect us deeply when we've lost a friend or a loved one to an injury. And I would wager that most people in this room have either been to an emergency department themselves or have been with a family member or friend to an emergency department for an injury at least once. And I bet most all of you can also remember someone who you knew in your teenage years who was killed or seriously injured in a motor vehicle crash. Since President Bill Clinton signed the proclamation declaring the first week of April National Public Health Week in 1995, he's signing something else here, I don't know, NAFTA, something not as important as Public Health Week, but important. But the point is that since that time, 2.1 million Americans have died because of injury. This includes more than 400,000 children and young adults, over 1 million adults, and over 500,000 of the elderly. Numbers don't always tell the story, but maybe this visual graphic will stay with you better than the numbers. This is the leading causes of death chart from 2007, showing the rank order down the left by age group across the top. It's a chart that in the injury center we're not allowed to leave home without. It tells very graphically the burden of injury in the U.S. The blue boxes are unintentional injuries, the red boxes are homicide, and the green boxes are suicide. Together, they make up the injury problem in the United States and demonstrate vividly that injuries are the leading cause of death from ages 1 to 44, robbing society of many of its most productive members. Actually, stories about real-life people may be even more compelling than fancy graphics. This is Dan McLathery, who was 22, who drove a big truck, and he felt very comfortable and safe in his big truck, and very uncomfortable when he wore a seatbelt. But he was stopped at a seatbelt checkpoint, and he was, after being very annoyed that the police would be spending time on such a trivial issue, he decided that the fine was enough to get him to start wearing his seatbelt regularly. Soon after receiving that citation, Dan lost control of his truck, flipped it over, and was hanging upside down. Despite the severity of the crash, he avoided becoming one of the statistics. He was alive and not seriously injured. After that experience, Dan found the police officer who had issued the citation, shook his hand, and thanked him for saving his life. Research has demonstrated the effectiveness of well-enforced laws like this one. And Dan's advice is, there are steps you can take to prevent injury, and you need to take them every day, every time, since you never know when something might happen. And that's the message of National Public Health Week. This story leads to the second answer to the question of what's so great about injury prevention. It's that you have solutions to offer. We're not struggling to find a gene or a drug to fix the problem. For example, we've come a long way in learning how to protect kids in cars. Car seats significantly reduce the risk of death and injury in a crash, and we have, as Dr. Sharfstein said, even more effective car seats today. Bicycle helmets reduce the risk of serious head injury by 85%. Smoke alarms cut your risk of death in half in the event of a house fire. One of the 10 greatest public health achievements in the United States, according to the CDC, in the past century, is motor vehicle safety. And what this chart shows is from 1925 to 1995, increasing vehicle miles traveled, significant increases in vehicle miles traveled in the green line, and significant decreases in deaths in the blue line. These successes in injury prevention happen through discovery and implementation of those discoveries that were comprehensive in their approach to make environments safer, to enforce appropriate policies, and to educate the public. Which leads me to the third and almost final answer to the question about what's so great about injury prevention. You get to work with people from many different disciplines. Prevention specialists come from epidemiology, law, health policy, behavioral sciences, health promotion, and health communication. I hope you'll have time to take a tour of the Mobile Safety Center pictured here as an example of some of our community prevention work. We work with law enforcement officers, government agencies, and elected officials. For example, work from the center demonstrating the importance of comprehensive graduated driver licensing laws has been used by many states to help shape teen driving policies. Injury prevention professionals get to work with engineers and product designers too. For example, center faculty worked with engineering students from the Homewood campus to design an improved and now patented helmet for whitewater rafting. Health services researchers and medical care providers are essential for helping us understand how to prevent injury and to improve trauma outcomes when we can't prevent an injury. For example, working in partnership with the American Trauma Society, center faculty have developed innovative programs that improve the quality of life of trauma survivors. This multidisciplinarity, if that's a word, of the field makes it clear that just because we aren't looking for a gene or a drug to fix the problem, it doesn't mean that we don't have science behind us. In fact, some would say, as was mentioned already, that the science of treating injury as a public health problem was launched here at Hopkins, making it even more fitting that APHA is launching this Public Health Week with us here today. When Professor Sue Baker, pictured here, started the Johns Hopkins Injury Prevention Center, as it was called, in 1987, she brought the science of epidemiology to the study of injuries and established what is now one of, if not the, oldest and largest Center for Excellence in Injury Research in the world. And this brings me to my final point, that is, what is so great about injury prevention specifically here at Johns Hopkins? Hopkins has many injury resources and researchers in many different departments, including health policy and management, international health, population and family and reproductive health, mental health, and health behavior and society. Our Center in Health Policy and Management remains alive and well, and we're looking forward to celebrating our 25th anniversary next year. We're home to 17 core and 25 adjunct faculty from both inside and outside of the school, representing all the major disciplines necessary for injury prevention research. And this slide shows you that we're dedicated to conducting research that identifies effective policies and programs, making sure that's translated into action, and integrating all of this into the training of the next generation of injury professionals. With all of the faculty across the school, we're able to offer 10 courses, a certificate program, train more than 150 public health students every year, and our center offers a summer institute that has trained more than 600 practitioners in the field. So in conclusion, to continue the progress that's been made, we must continue to grow the field and we must expand our partnerships. We would welcome the opportunity to work with each of you, and we heartily thank APHA for choosing to focus national attention on what we think of as a most important public health problem. Thank you.
Thank you. If the speakers wouldn't mind coming up here, we probably have time for a few quick questions while they're coming up. I know that Sue Baker, Sue, raise your hand so everyone knows where you are. Sue Baker has been mentioned a couple times, and we ought not to overdo this, but if you looked at that slide that Dr. Gielen showed about millions of vehicle miles traveled and the death rate coming down, you would have noticed that the death rate started to come down around the birth of Sue Baker. Sometimes it just takes one charismatic person to change the world. Do we have some questions for any of our three distinguished panelists? Well, I could ask a question. No, I'm sorry, we do have a question. Thank you for covering both Monday and Tuesday of the week, home injuries and motor vehicle related injuries. Is there a response from the panel?
Well, first of all, I think we need to do a very good job of teaching people that we do have a very good EMS system and the right way to get people from a point of injury to urgent care or emergent care, depending on what they have. Particularly in Maryland, where we have an extraordinary system, the shock trauma system, and good medical control. Having said that, you know, I mean, that person was obviously trying to do a good thing, and I don't know what was preventable in terms of that collision, but the point I think that person should be told, and most EMS folks who are counseling people on the scene would tell them that that we have a good system, and they'll do whatever they can for that person when they pick them up and take care of them. And they should talk to they should talk to someone, and they shouldn't feel that because they did a good job as a first responder, as a good Samaritan, that they didn't do the right thing.
It sort of recalls for me the issue which has been discussed as a policy issue about appropriate rules for police pursuit and the challenges of safety for the police. There was a period in Baltimore when I was the health commissioner where there were a number of police officers killed in traffic accidents while they were responding things, and there was a question about what's the appropriate training, what's the appropriate rules. Even the police going through red lights, it's not, you know, unheard of at all for there to be a serious complication from that. So, you know, and then I guess if, you know, it's possible that if people see the police driving in a certain way, they think if there's an emergency, that's what they should do, and that could create a problem. So it's an interesting, I think that would, you know, count as an interesting challenge to try to figure out what's the right way to do that, because you could see that they're kind of both sides of the coin. You don't want the police going super slow when they need to get somewhere. On the other hand, you don't want, you want to figure out a system to make it safe when they're out there.
One more quick question, and then we come to a very fast event that we're stay in your seats, but quick question, yes.
I'm going to take Dr. Sharfstein up on his invitation. So this is a banner day for Hopkins, but despite that, there are still things that this institution does not do to fully support injury prevention. Children across the street literally could receive millions of dollars in care for tertiary care, but leave the hospital, could leave the hospital completely unprotected from the leading cause, the leading threat to their health. Not that the institution does not have a car seat policy. How can you help us change this for not only our institution, but for hospitals in the state of Maryland? Good question.
We might be out of time.
Well, you know, I think that it's important to ask questions like that. And, you know, I think I'm familiar with babies not being allowed to leave the hospital unless there's a car seat. I don't know.
It's not an institutional policy.
Write a letter to the president of the university.
Sorry?
Write a letter to the president of the university, the president of the medical center, and then CC me on that letter, and I'll be happy to write one too.
Yes. So part of our work here, and a very important part of our work here on preventing injuries, is the partnership that the faculty have with the students. It's the students who stimulate the faculty. It's the students who do the work of the faculty sometimes. And I'd like to introduce to you Cassandra Kircher, who is one of our injury prevention students, who is going to raffle, is it a BMW?
I wish.
Okay.
Throw myself in the mix. Hi. So as part of National Public Health Week, we have created a social media campaign. And so we're asking members of the Hopkins community to share their injury stories, how an injury has affected them or a loved one or a family member, and so that we can help raise awareness of how injury affects us on a daily basis. So we've got this Facebook page. It's facebook.com/Hopkins Injury Stories, where you can post your story. And we're going to be doing this for about a week. And students who share a story are going to be automatically entered into a raffle to win a CO monitor, a fire alarm, or smoke detector, or a $20 gift card to Jay's. So, you know, we kind of have the injury gifts in there. So if you could join this page, you all have flyers that have the address on there. So share your stories so that we can help make injuries a thing of the past, hence histories. And so for the students that are here, we're going to be raffling off an opportunity to go on the tour with Dr. Sharfstein and Dr. Benjamin. So pull out your tickets if you're a student, and we're going to raffle off a couple of these really quick before I send you off to lunch. So the first one is 185334. Yay, all right. Sounds good. All right, and the second one, 185315. Score. All right. And so you need a ticket for lunch because we have food monitors. So if you did not get a ticket when you come in, see me on the way out and I'll make sure you get a ticket. So thanks everybody for coming.